Lady from Manchester.
Yeah. Hi, yes, from Manchester. My question is in terms of transplantation, about research in changing the blood type of kidneys to the universal O to kind of, be able to do more transplants. Is that something that, what are your thoughts on that?
Yes, actually, it was Prof. Mike Nicholson's research from Cambridge. This is done very recently, I thought, in one patient. If I remember correctly now, I'm not very, very clear at the moment with my mind. I'm a bit tired. But blood group O giving to blood group AB donor, for example, if he has to go give blood kidney to A, then passing blood and some chemicals through this kidney will delete the B group and convert this kidney suitable for donation to the corresponding group. I think he has tried that, the deletion of some chemical structures in that kidney by putting some fluid, some chemical agent through the kidney. He has done that in one, and he has done a lot of research on that, on animal models. That will help some of the patients on the waiting list who had been waiting for a long time, not getting the proper kidney. So, and that happens particularly in minor ethnic group population. I think that's what his interpretation is. We examine together in FRC's exam 2 or 3 times a year. We meet in various places. And in the evening, we sit down and have a chat together. And he tells me that this is going to be quite promising in the future, but it's in the very experimental stage at the moment. But he has tried, I think, in one patient, and that came in the news not very long ago, a couple of months ago, that was in the news. So that is in process.
Okay, I've got a couple of questions online. Two sort of related for Matt to do with tolvaptan. So kind of related in some way. First of all, how long can you take tolvaptan? Can you take it forever? When would you stop? And second is tolvaptan in later stages of PKD. So kind of related, but slightly different.
Yeah, they are. I suppose they are kind of related, aren't they? So the first question was about when can you take it and when can you stop, wasn't it? So you can take it for the rest of the function of your kidney, and like Albert mentioned before, you do have the sort of sustained benefit of the treatment. Then, I suppose if you're having a significant drop in your kidney function, which some people do, if you're being dehydrated, so if you're unable to keep up with the fluid, that might be a reason why people might stop. And the second question is about why not at the lower stages, wasn't it?
Yes, so somebody who hasn't probably been on it before, but as a later stage, can they, and what, the later stage is not defined by the questioner, but, what stage what's the latest stage you would start, let's say?
I suppose all the trials have been done down to 30. I think beyond that, Albert mentioned there's a couple that have been done in stage 4, but actually there probably isn't enough evidence to really say what benefit there is to be gained and what the risks are of being on tolvaptan at that stage. And that's probably the benefit is maybe how much time someone has to be on it. So if you can only be on it for a short amount of time before you reach end stage, you might not get the benefit to balance out the risk that you would have had from the symptoms, or the perceived risk from the symptoms. I think the answer is no one's really done that research yet to that level, and I suppose it's how much extra time it would gain you and whether it would be worth it in the patient's view. That's kind of what I'd be thinking about.
Thanks. We have another question on hormone replacement therapy. So I'm not quite sure who's best placed on. Ros, could you answer that one?
I can try. It depends on the question, but I'll certainly try.
Hormone replacement therapy and PKD, because of the potential effect on polycystic livers with replacing estrogen, so estrogen loss.
So usually in this thing, either very echoey or very quiet. So usually we try to suggest avoiding estrogen, because of the potential adverse or bad effect on polycystic liver development. So in the same context, I would suggest that probably avoiding HRT would be what we would suggest, but I would probably have a further up-to-date look at any literature, any specific drugs, before completely suggesting to avoid it. And I haven't done that recently. Okay. If I may say very briefly about tolvaptan, so we wouldn't usually start it if the GFR percentage function was less than 30. We would continue up to 15 or down to 15, and usually then we would say stopping it. And usually then you get, like some other drugs, you get an improvement in kidney function, but if it then bounces back to 18, we don't usually restart, if that makes sense. So whatever benefit you gain in function going back up, you just benefit for that period of time.
We have another one probably for Albert. Well, it's more than one actually. It's popped up a couple of times. Something you didn't quite mention in your talk was about gene therapy.
Deliberately.
Not letting you get away without answering that one, because we often get asked it, of course. Charity.
So you want me to talk about gene therapy?
Yes.
Okay.
Please.
I think I kind of addressed it a little bit from the previous, when I was a question about gene editing. That's not exactly the same as gene therapy, but I guess the same problems are there at the moment. So we can, so say some of the genes are very large. So there's a technical issue. So PKD1, for example, is a very large gene to replace. Secondly, we need to express them. We need to get them to the cells that need it at the right time and keep it going for the length of time we need. So introducing, so if you just inject the gene, the virus that contains the gene, which is how most gene therapy is conducted, directly into the bloodstream, most of it gets taken up by the lung. To get it into the kidney, you have to almost do it direct injections into the kidney, which is doable, but it's not trivial. And then to make sure that it kind of continues to be expressed for the length of time you need, or to keep repeating the injection. So you can imagine, I don't think this is kind of easy to do, and I don't think at the moment people are even thinking about that. So because it's just not realistic. Most of the things you can do in animals, you can't really do in man. So now one form of sort of gene targeted treatment, which is looking interesting, is again, works well in mice. So lots of things work well in mice, but I think the hope is to try it in humans. And I think so that's where they are trying to increase the expression of so we carry one faulty gene and one normal gene. So, you don't have two faulty copies, if you like. You got one faulty copy, one normal copy. So this type of treatment is to try to increase the expression of the normal copy to compensate for the faulty copy, which is quite clever, but basically, that again, as I said, was reported this year in animal models. It works really well, but I think whether we can then take that into man, take a tablet or have an injection, increase the boost, if you like, the normal copy to compensate for the loss of the faulty one, is that enough to prevent cysts or even reverse cysts? So that's the kind of probably quite exciting, but I think it's still, I would say, very early days. So that's kind of a form of gene therapy, but it's not replacing the faulty gene. It's actually looking at the gene that's still there and trying to switch it on more, boost it, if you like. So I think that probably has an interesting story there. So, yeah.
Would it help to say what we are doing in terms of gene therapy? So where it is working and where,
yes,
and where, so which might explain why it's perhaps not working in renal medicine.
Okay.
So the areas of gene therapy that are currently being used are for those genetic diseases where you can easily access the tissue. So probably the main one at the moment is retinal eye disease. And so what's going on there is that a correct copy of the gene is sewn into a viral vector, and then it is injected under the retina, so a blob of fluid containing the gene with the viral vector is injected under the retina. It's then taken up by the retinal cells, and that work has shown to, in the best cases, probably stop the decline of the loss of visual acuity, so halt it but not cure it. Another area where there's some success is in some of the blood-borne genetic conditions, because you can take patient's blood out, put the correct copy of the gene in, and then retransfuse them. So again, you've got direct access to the tissue. The other areas where we're using it are in newborn babies with a very severe neurological condition called spinal muscular atrophy, or SMA. And we're injecting that vector into the spinal fluid. So this is not a tablet. This is quite invasive treatment to get these genes to the point where they can actually have an effect. And probably the other area that is being looked at is some of the neurodegenerative conditions where the disease is caused by the accumulation of the abnormal protein that's poisoning the cells. And so if you can use some things called oligonucleotides to block the protein production from the abnormal gene, then you prevent that abnormal accumulation of protein product. So gene testing at the moment is very focused on areas where you can get to the tissue and there is a very specific thing that you can interact with and stop happening. Now, the problem, I think, with polycystic kidney disease is that this is not like that. This is the, from the moment of conception, the cells in the kidney are behaving in an abnormal way. So your timing, probably by the time you're born, is probably a bit too late. And you've got to get to a difficult to get organ where there's no way to easily access it. And so I think that it's going to be, unfortunately, quite a way down the long list of possible genetic conditions that are going to be amenable to gene testing, to gene therapies.
Thank you. Audience, do we have any more questions? Oh, lady over there. Joanne.
I've got PKD and I've also got IgA. This is for Jackie. Is it connected?
So the textbooks say that IgA nephropathy is not inherited, and that's probably true. Having said that, we have a very small number of families where we have got what looks like transmission from one generation to another of IgA nephropathy. But unless Albert's going to tell me otherwise, I don't think any gene has yet been identified that causes IgA nephropathy. Or do you think there's one in the offing?
No, it's not a single gene disorder. So there's strong genetic components, but they are, probably 20 to 30 different genes that can make you more at risk of developing IgA, but none of them are related to PKD. So it's a coincidence. So, yeah.
Any more questions?
Yeah.
Oh, come on. Oh, there we go. We've got another at the back. It's the troublemakers in the back there.
Keep running.
I'm only kidding. I'm only joking.
Hello. Please, you talked about kidney transplant earlier. Please, can you tell us what happens to the kidneys that have got PKD that are left inside if you don't have a kidney removed? Okay, I'm told that doesn't make sense. Okay, if I have PKD and I have a kidney transplant, and my kidneys that have PKD will still be inside me. Yeah. Yes? Can you tell us what happens to the kidneys inside you? Does it still give you the same problems?
Yes, I think several people have transplant, and these own native polycystic kidneys, which are not causing any problems, are left behind. So some of them tend to grow with time and start having problems in them. say, infection or hemorrhage, stone formation. And if that becomes problematic, then we have to remove that kidney. But otherwise, we just leave them alone. We don't do anything. We don't touch them. I showed you one slide where the Japanese experience was published. It says after 1 year of kidney transplant, in 37% of the patients, the kidney shriveled actually quite a bit. And in 2 years' time, it has gone down size by, lost by 40%, reduction in size that happened, whereas the liver, it keeps growing. So unless the kidney has some problems, it's causing some symptoms and compromises quality of life, we don't have to do anything. In fact, there's an advantage of having these kidneys, because if the transplant kidney fails and these kidneys keep producing urine, then you at least don't have any problem with fluid management. Or these kidneys still produce erythropoietin, for example. These kidneys tend to actually give some quality of life, even if they're not working. That's why we don't recommend having both kidneys removed, if possible. The quality of life certainly changes. The fluid intake, the diets, everything actually changes. So having the native kidneys, even if it's polycystic, is an advantage.
I'm sorry, I don't know if I agree with you there, being the fact that the polycystic kidneys still have these cysts, what can then burst, give you infection. And what I'm asking you is that once you've had your transplant, these kidneys, will they still be prone to infection and kidney bursts? That's what I'm kind of asking.
Yes, this can happen. I mean, there are several patients who have had these problems, and I have removed few kidneys after transplant as well, if they've had these problems. But many people don't have any symptoms, so why bother to remove them? Symptomatic polycystic kidneys do need attention, definitely. I mean, infection after having transplant could be very serious because of these anti-rejection drugs. The infection could flare up very rapidly and can harm the transplanted kidney, actually. So it's a balance, basically. Every case has to be treated on its own merit.
I think if I may say, it's like a lot of it's very personal, so what's, right for one person isn't right for another person. And so sometimes people do have to have a kidney taken out before to make space for the kidney. And other times, they don't, and they can get away fine. And it's not a straightforward operation, say, although even now parts of the country are doing things robotically and so on, but I think it's not without risk. So usually we try to personalise things.
I think the question was really I think you were trying to understand, once you've had your transplant, the symptom, the issues that you were having pre-transplant with your polycystic kidneys, do they continue? I think that's what you're trying to establish, and I think what the panel's saying is, in some cases they will continue. In other cases they may not. In some cases the kidneys may shrink over a period of time. They may get smaller. The polycystic kidneys may get smaller. In other cases they may continue to grow. Is that correct?
Absolutely.
Yeah. Great.
Yeah. And it's a major operation. Removal of kidney, nephrectomy is a big operation. It's not without risks, obviously. There are several patients who have been in hospital for months after nephrectomy because of infection issues. So if the cysts are infected, some of them do rupture during removal, and they can contaminate the wound. Abscess can form inside the abdominal cavity, and that may last for months. So the decision has to be made very carefully.
I have an online question probably for Jackie to do with IVF. I know you spoke about it from a technique point of view, but if somebody was interested in it, what's the best way to proceed?
So if a couple were considering PGD, the first thing that we need to do is identify the mutation. So that might already be identified, but if not, so pre-implantation genetic diagnosis. So the first thing is identify the mutation. So we need to work out which gene and what the pathogenic variant is in that gene, because unless you know that, then we can't offer that. You then are referred to a PGD clinic, and there's one of those. Sheffield is one of the centres for pre-implantation genetic diagnosis in the UK. And what will happen then is that you will have an assessment. So the things that people have to look for in terms of IVF treatment is, first of all, age of the woman comes into it, because as a woman gets older, it's less and less likely to be successful. So age comes into it, weight comes into it as well, because the danger of stimulating the ovaries increases with the weight of the woman. So we might have to ask somebody to lose weight, because it just becomes too dangerous if not. And then we start the genetic workup, because the laboratory, which is done at UCL in London, has to be able to do that gene test on a single gene. And sometimes in order to do that, there are various techniques that we use, including tracking the gene down. So often we might ask for blood samples from the couple and also from the parents of the affected, so that we can work out the genetics, because we can't start going ahead with IVF until we know we can do the gene test on a single gene. When it comes to IVF, what then happens is that we have got to get the ovary to produce lots of eggs at one time. So that is done by hormone injections. So what we do is, with hormones, we put the woman into a chemical menopause. We switch her ovaries off. We then, with another group of hormones, switch them on. And that switch from being off to on causes hyperstimulation of the ovaries, so that the woman produces lots of eggs at the same time. That itself is not without risk. And therefore, that's where the weight comes into it and age comes into it, try and minimize that risk. The eggs are then collected using ultrasound scan and a fine needle to collect the eggs from the ovary, and then they are fertilized with the partner sperm outside the body. And we grow the embryos up to about an 8-16 cell stage and take a single cell at that point, so that you can divide the embryos into two groups, those that carry the gene fault and those that don't. We usually only implant one nowadays because of the risks associated with twin pregnancies. And we freeze the remainder of the unaffected embryos so that you can go back for a second cycle. In terms of funding, it is available on the NHS as long as you do not have an unaffected child. So if you have an unaffected child, it is not available on the NHS. Once you've had a successful event with PGD and you have an unaffected child, further pregnancies are not available on the NHS. But if you have frozen embryos, it is significantly cheaper to have an implantation of a frozen embryo than to go through the whole cycle of PGD again. It is not an easy way to get pregnant. It sounds, you can say that and go, oh, okay, that's fine. This is a very difficult way to get pregnant. And what I would say about the ovarian stimulation is you go through a chemical nightmare, and it is not pleasant. But obviously, if you know that at the end of it you'll have a baby who does not have PKD, then that's a decision that some partners would opt for. But I think you have to start off the process saying that from beginning to end, you're probably looking at a year to get it all sorted out, all the genetics lined up. Then you may have to go through more than one IVF cycle to get any viable eggs. So it's difficult. And I think one of our roles is to make sure people understand what they're getting into before they suddenly find themselves in this kind of roller coaster.
Thank you. I've actually got a question that was emailed in to us, and this was from a PKD patient, a lady who was concerned that her daughter, who was in her early 30s, was refusing to be tested for PKD. Of course, she's at risk of inheriting it, as we know. And she was sort of burying her head in the sand, and the mum was worried about it. And was there anything we could do to help? Which, of course, we can't force this issue. But what would be the risks to the daughter in her early 30s of not being tested?
When I was a renal registrar in the dark ages, and something you don't really see anymore, is you would see people coming in extremis, in acute on chronic renal failure, with a known family history of PKD, all of which was entirely avoidable, and they were very, very ill. And one of the things you don't see much, well, you probably see it a bit, but much, much rarer, is that happening. And renal problems can creep up on you. So you may be asymptomatic for quite a while, and then suddenly you are not asymptomatic anymore. So if you do not get diagnosed early, that means that you are not being under review. People are not keeping an eye on your blood pressure. People are not keeping an eye on protein in your urine. And so the risks are that we talked about the variability in families, and one of the components of that variability is the type of treatment that you receive as you go along. If you don't get any because you're undiagnosed, then you run the risk of much earlier renal failure.
I think if I may say, if you don't want to be tested, you should at least look to exclude certain risks. And I think blood pressure is one of the most sort of common problems. So at least get your blood pressure checked, because that's not diagnostic, but it's a very treatable thing. Or you could at least get your kidney function checked, so that if you don't want to know for 100%, at least you can know if your kidney function is changing, and then you can think about it again. So I think at least have a blood test at some point, or at the very, very least have your blood pressure checked. And I think that's why the children doctors amongst us tend to recommend that children have their blood pressure checked, because even then, if it's not diagnostic, there's things that can be done. So I think the first thing, as many of us think, is do no harm. So don't put yourself at danger. So get your blood pressure checked. Do things that we can do something about. I think obviously it's got huge implications, and some people don't understandably want to think about that, and I completely understand that, but at least don't put yourself at unfair risk. So get your blood pressure checked.
I guess can I just add a little bit? So I would probably want to try to understand why she doesn't want to be tested, because people have many reasons for not being tested. Is it fear about what that could mean? Is it about insurance? I just can't, or life itself, because I got just too much on, I can't take on another stress. So it's better not to know now. And it's interesting actually how people change, because I think some of the things that make people change, like, getting married, deciding whether to have a family, sometimes seeing what happens with someone else who didn't get tested till late, and oh gosh, maybe that's a warning sign, I should get tested. But I probably would like to know why, if that's possible, to know why that person is opting not to be tested, and then just talk it through, I guess. Because in the end, it's everyone's right to be tested, not be tested. That's your right. So we're not there to say you have to be tested, but I guess we want to give you the option and, say that actually there's benefits of knowing early, but I guess understand why you think it's not a good thing. Yeah.
But what you're saying there is that there are some early interventions or early diagnostic testing that can be done, such as checking blood pressure, which sort of hypertension could be one of the early signs of polycystic kidney disease. I think there was a question there, Tess, that popped up in the chat about blood pressure for a child. Are you answering that?
Tess is going to answer it.
Tess has been typing all day.
No, I'm just keeping people informed. Yes, indeed there is. There is a question about the ideal blood pressure for a 12-year-old, but I was referring the individual to some charts and so on. But by all means, adult kidney doctors on the panel, please answer. Is there somebody in the...
It's a 14-year-old, and that question came up earlier. should her blood pressure be?
So the lack of rush.
There are charts.
Yeah.
I said that,
yeah.
but now that we've got you here,
There are charts.
I think the lack of rush is probably, if I may say, is the lack of knowledge. And so we are effectively doctors for people who are above 16 or who are more adult. And so therefore we would bow to the expertise of someone more qualified or to a general practitioner who's more qualified than us to answer that question. But usually it's an age or height related level. And so I would refer to that. That's fair.
ooh, question there.
I think he went first.
Oh, were you first?
Just keeping it on the blood pressure sort of related topic. I had my blood pressure checked, and as each year I've been for a check, my kidney function has come back as normal as part of the blood test. My cysts were only picked up as part of my tumour on my spine. I'm being scanned for everything under the sun. So what awareness is there with GPs that if the blood pressure's still high, the medication's not working, that there should be a further referral on somewhere else?
Well, I guess it depends probably on, in some ways, to certain GPs, and we've got some amazingly good GPs amongst us, and we've also got some that know less about certain areas. You know, everyone's got their own areas of expertise. I think if someone's still developing problems or has problems and, you know, things aren't answered, I guess we all try to keep looking. Yeah. Mm. Yeah.
That's 3 sets of GPs and 3 sets of regions. It's been the same result that nobody ever say that this could be part of something else.
Mm-hmm.
And nobody's ever done anything about the medication. It's just 10 milligrams or morphine.
Mm-hmm.
That's the answer. An exercise around how many what time do I need to get out of the bike? How much more exercise do you want to stop working?
Yeah. So, yeah. 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 It's not right. Yeah. It's not right, but I think you do have to keep knocking on the door. You know, I think if anyone would say, you know, sometimes, you know, just keep knocking on the door or keep trying. You know, I think because sometimes if we sort of wrongly assume that if we don't hear from someone that things are okay, and that's not always the case. And sometimes people can be suffering a lot and not reporting or trying to get through, and we don't know you're trying to get through. You know, so. That's right. That's right. Yeah. Mostly. Yeah. Sure. Mm-hmm.
I think probably briefly, I think there's definitely more education to be done to GPs and, you know, in terms of awareness of rarer diseases. On the other side, I think GPs actually, even if we say, this is the most common genetic disease affecting the kidney, probably in average practice would probably only have 1 or 2 patients that they ever see. So it's quite difficult to get specialized. So the GP has to know a bit about everything. And sometimes, they don't. So that also makes a case that maybe, it would be wherever there are centers around the country who specialize in, say, PKD or something else, that the patients should be seen there at least once or twice so they get the latest advice. So that's probably what you could say, to your GP, could I be referred to see, and get, full advice about my condition. Yeah. You didn't know, yeah, absolutely, yeah. Okay. Yeah. It's related, yeah. Okay. That's true, yes.
I think you had a question, didn't you?
If a living donor has had all... If a living donor's had all the tests and they're compatible to donate, but the person they're going to donate to hangs at an EGFR that doesn't mean that they need the kidney there and then, is there a use-by date on all the tests that the donor has had?
That's a good question.
Sorry, I couldn't get it again.
Sorry. I've had all the tests to be a living donor, but the person I'm going to donate to is hanging at an EGFR where they don't need a kidney, and they've hung that place for about a year. Are my tests, am I going to have to go through them all again because it's a year before they actually had them?
That happens quite often, actually, because for example, the recipient's GFR is 15 and we wait till it drops below 15. It may take sometimes 2 years, for example. The GFR improves to 16, 17, and it is just wobbles around. I say, we don't have to repeat all the tests of the donor because the CT angiogram is not going to change. And all we do simple blood test, EGFR, one blood test. We find out if it's stable, then we don't have to do anything. And that is done maybe every year or so. But sometimes we leave it till a couple of years. And then we do again, it's most of the time it remains stable, it doesn't change. If it has changed dramatically, then we do the proper major GFR, isotope GFR. That's what we do. But majority of cases, no, it's simple EGFR estimation. Usually that's more than enough.
Well, my EGFR came in at 72. So I had to have the GFR with the radioactive isotope, and that came in at 92.
Yes.
So would I have to have the radioactive isotope again? Because I'm presuming the EGFR might be something obscure like 72
Unless it's
again.
3 or 4 years down the line, we may have to rethink. But the EGFR gives a lot of information. There is national guidelines on that about the cutoff GFR for certain age. So we follow that protocol. Say if you are 60 and then come back at the age of 70 for donation again, then we clearly have to repeat everything. But within a year or two, we don't expect it to change dramatically. Yeah, thank you.
And it's meant to be in your best interest. It's meant to be trying to protect you, obviously, in case. Yeah. Yeah, okay. We'll catch you next time.
We've got another question here.
Hi, thank you. Yeah, from Manchester. So my question is around, well, it's about the discussion we had about children, adult children, refusing to get tested and the risks with being undiagnosed. So my daughter's 23 and I've got PKD. I'm a mutant gene, but obviously there's a risk that she's inherited it. She doesn't want to get tested and I'm not going to force that. But then there's no sort of support for her to kind of maybe, because if I said to her, I don't need to have salt, I don't need to do this, she's just going to be like, jog on, mum, But there's no sort of support for her as a potential patient to come forward and have some kind of screening. And is there anything, you know, within the pipelines, within, you know, for these kind of potential patients, is there anything in the future? Do you understand what I'm asking? You know, for potential patients to come forward, you know, children.
I think the PKD Charity app, if I'm allowed to say, could be very useful. And it's obviously modern. The fact that I even use the word modern shows I'm old. But
you also said ultra modern, so that's even worse.
Probably yes. But I do think that probably just, you know, things like the PKD Charity, you know, is a fantastic support, and I think we're very lucky that, you know, it's trying to look ahead and find different ways of approaching people who are clearly a lot younger than many of us. And it's, you know, I appreciate, you know, you've got children and you don't, you know, you're obviously worried about them hugely, but you can't force them to do things they don't want to do. And all you can just say is just remember, you know, that I'm there, or other people are there to try and help support you when you're ready. It's all about when they're ready, isn't it? You know, it's when she's ready to have that. And of course she wants to go off and be wild and have fun. So do I.
Yeah, I mean, absolutely. In the meantime, what she has got through the charity is access to information. So, you know, obviously there's the website, there's events like this that she could come to either in person or online. She's got a helpline that she can call any time and talk to somebody about her concerns, her reservations. She's just shutting it all out. Yeah. Well, I mean, that's a tricky one, isn't it? I mean, there's a Facebook group she can join. You can join that. You know, there's... Yeah. Yeah, but what you can do, which was suggested before, is perhaps talk to her about some of the things that she could do, such as having a blood pressure checked. You know, that might actually sort of, you know, if she went and had blood pressure checked and found it to be very high, that might sort of trigger her to sort of take some action. Alternatively, it could be fine. But you know, there's not a lot. You can't actually force her. She is an adult. She's not a child. And if I think we could... Albert, did you want to ask?
I'd say that probably she wouldn't want to be in a Facebook group as a mother, probably, but...
No, that's true.
But you could take some leaflets and leave them around the house, maybe, and just sort of...
Wallpaper a bedroom in them. How about that? You could borrow that banner and put it in the lounge.
Stickers, you know. Anyway.
Wendy, do you have another question?
Oh.
But could I say that to any healthy member of a family where there is PKD, the quickest way to an NHS-funded full MOT assessment of one's own health is to offer to be a donor?
Okay. Superb. Okay.
Full MOT.
Right.
Free of charge, no questions asked.
Okay.
And it's very good for me.
Badri.
Can we say that you're a donor, Wendy? Yes.
Okay. You get a full check for free. Okay.
Right, I think we're all right. We've exceeded time.
Okay.
We're going to get thrown out any second. I think my mind could die. I am dead.
I'm dead.
I'm dead, Tom. But we'll take one more question if there is one. Come on, last chance.
That's it.
Was there no more questions?
No. What's wrong with your mic?
So Nick wants to know what's wrong with the mic. It's working now. Okay. No, it's working, yeah. So no more questions. That's sort of wrapped up then, really.